يشرفني أن أقدم زميلتي الدكتورة نيلي زيادة. She is the president of the Lebanese Society of Rheumatology, and she's also the head of Rheumatology Department at the St. Joseph University of Beirut. She's the president of the ARCH اللي هو الأرلار ريسيرش جروب. وهلا عرفت إنه قديش هي نشيطة بالريسيرش لأنه عندها PhD in Epidemiology from Paris, Fifth University. طبعا يعني هي ممكن بعرفش أنا ممكن أكثر زميلة مهتمة بالريسيرش وبتنشر publications. دكتورة نيلي أهلا وسهلا بك، تفضلي.
شكرا دكتور أنس، السلام عليكم. بشكر الجمعية الأردنية لدعوتي، وسعيدة جدا بوجودي بالأردن، وسعيدة كمان أن دكتور أنس معنا. بشكر كمان نوفارتس سبونسر هذه المحاضرة for offering solutions for our patients. So I will talk about disease control to patient outcome, centered outcomes, the Cosentyx perspective in axial spa. So محاضرتي رح تكون ب5 نقاط على عدد البلدان بالليفنت. رح بلش بcase from the clinic, then I will talk about interleukin 17 as a key inflammatory mediator. Then I will tackle the key clinical trials in axial spa, some trials about strategy trials سميتهم اللي هن الهيد تو هيد and real world evidence, and finally أكيد رح نخلص مع السيفتي data. So let's start from the first point, the first country, Lebanon. My patient is Mr. Fadi. He is a 43-year-old smoker, Ballat, Tyler. He has inflammatory back pain for 5 years with significant reduction of daily activities. Yani this patient is not capable of working anymore. He previously used NSAIDs as needed, but his cardiologist said, no, you should stop, you have hypertension. He has no other manifestations. On physical exam, he has limited lumbar mobility. He has pain on the mobilization of the sacroiliac joints, and he has also a metabolic syndrome. He has high blood pressure and a BMI in the obesity range. Lab showed CRP that is high, negative HLA-B27, and HbA1c of 6.2. Family history is negative as far as we know. So the imaging came to confirm the axial SPA diagnosis. Pelvic MRI show bilateral asymmetrical sacroiliitis with bone marrow edema and several erosions, which is the hallmark of the disease. Pelvic X-ray showed bilateral sacroiliitis grade 2, so he has axial SPA, radiographic axial SPA or ankylosing spondylitis. And the spine X-ray showed no syndesmophytes and few osteophytes. The ASDAS CRP was in the high activity range. So as my patient Fadi, patients with axial SPA suffer on a daily basis from the hallmark of the disease. They have a significant impact on work and a significant impact on their relationship. Morning stiffness, spinal pain, fatigue, nocturnal pain are all debilitating hallmarks of this disease. It can also happen to women. It's not only a disease of men. It's true that it can be a little bit different between men and women. Women are up to 2/3 of non-radiographic AXPA, whereas men are 1/2 of AS. Women have more neck and peripheral pain, and male have more thoracic, lumbar pain, and radiographic severity. But whether they are men or women, they are all suffering, and they're all worrying about their future. What will happen to me? Will Fadi return to his work and be able to provide for his family? And it's difficult to predict. Actually, I like this cartoon very well because it shows you like a river. From the pool of patients who have inflammatory back pain, they can have non-radiographic axial SPA. Some of them will stay quiescent. We all have these patients who are doing well. And some will progress. Some will remain non-radiographic axial SPA, and some will become ankylosing. And from the ankylosing people, some will not progress, and others will have a lot of complications. So it's a very large spectrum. Fortunately, we have some ideas about who will predict. We are not yet at the precision medicine here, but we can know, for example, from the JASPIC German cohort, that if you have high CRP, if you are a smoker and you have syndesmophytes, you have the higher risk of progression. So my patient here has elevated CRP, he's a smoker, he has no syndesmophytes, so his risk of progressing is 20%. So this is why we should treat this patient, and initially I started him on adalimumab. If you look at the recommendation of the ASAS recommendation for treatment, if the patient is non-responsive to 2 NSAIDs, or if he failed or had contraindications, you have to switch to the phase 2. Phase 2 is TNF inhibitor, interleukin-17 inhibitors, or JAK inhibitors. And due to the order surveillance data, now JAK inhibitors are not the preferred choice. Interleukin-17 inhibitors are the preferred choice if the patient has psoriasis, and TNF inhibitors are monoclonals, are the best choice if you have IBD or uveitis. So due to the availability and of adalimumab at the time, and it was more cheap, and he has no extra musculoskeletal manifestation, he was started on ADA. And at 3 months, he responded well. Back pain was reduced by 70%. CRP decreased to 7 milligram per liter. However, 6 months later, he develops this. So this is a complication that can be due to the disease or to the treatment sometimes, so the paradoxal pustulosis palmoplantaris. And so we switched him to secukinumab, and he was actually one of the first patients in my clinic to use this drug. And at 3 months, he had a clinical improvement. The back pain has almost resolved. The skin has improved. CRP decreased, back to work. And it took 6 months, actually, to resolve the skin disease. It was very difficult to clear, but the skin was finally cleared. So what is the role of interleukin-17 as a key inflammatory mediator? So it is excreted by cells from the innate and adaptive immunity. All these cells will secrete interleukin-17, which has really a key role in its activity on different actors, leading to inflammation, bone erosion, but especially what's important in axial SpA is bone formation. And actually, preclinical data, like this rat model, showed that inhibiting interleukin-17 will help reducing new bone formation. So we have two pathways. We have in PSA, AxSpA, and PSO. We have the mechanical stress, which will stimulate the innate lymphoid cells, neutrophils, mast cells. And you also have the activation. Look here, the TNF is upstream, working before the interleukin-17, and you have leading to the production of interleukin-17, which has a role in joint pain, axial pain, skin, enthesitis, dactylitis, and nails. And the use of Cosentyx, secukinumab, will inhibit all of this irrespective of the source. So now we will move to the key clinical trials in axial SpA. The main trials are called measure trials. The measure 1 compares secukinumab 150 milligram and 75 milligram versus placebo after an IV loading dose. So you have the loading dose, IV, and the placebo, and then you have the treatment, 150 versus 75 versus placebo. At week 16, everyone was switched to active arm. And the non-responders were switched, and the responders were kept under placebo for 24 weeks. So I highlighted the most important result. The primary endpoint was met in 150 and 75, and it was sustained over the 2 years period. The measure 2 study has similarly the same design. It is 150 compared to 75, but following a subcutaneous loading dose. And here the primary endpoint, ASAS 20, was met for 150 milligram only. The measure 3 is 300 compared to 150 versus placebo following an IV loading dose. And the primary endpoint was met and significantly greater at week 16 for 300 compared to 150. Now we use the dose 150, but just to know that numerically, the 300 dose was better on some stringent clinical endpoints like ASAS-40, ASAS-PR, and especially in TNF inadequate responder patients. Measure 4, it's secukinumab with and without loading regimen in patients with AS. So should we use the loading or no loading? And actually, it's interesting from an epidemiologic point of view, the primary endpoint was not met because the two active arms were similar, but the placebo arm had 47% response. So compared to placebo, it did not meet significance, but with and without loading dose, it was also the same range of efficacy as the measure 1, 2, 3 studies. Now, with non-radiographic axial SpA, we also have data, but the data is a little bit shorter, 555 patients over 2 years. And again, the primary endpoint were met in TNF-naive patients, and significantly higher with 150 compared to placebo with and without loading dose. So I summarized in this slide shows a more friendly summary. So if you see here the non-radiographic and the AS, you can see that ASAS-20 was reached by 76 and 78% of the patients, and ASAS-40, 66 to 67%. So in your mind, if you compare to the TNF data, usually we aim for ASAS-40 for 40%. So with this, we also have a very significant effect on all the hallmark of the disease, the morning stiffness, the spinal pain, the fatigue, the nocturnal pain. And the interesting thing that this is also sustained over 5 years. So you see the numbers for all the symptoms are similar at 1 and 5 years. Now, if you look at older criteria like BAS-DAI, we know that the cutoff of 4 is a cutoff where the disease is active. And you can see here very clearly that in non-radiographic and in axial and radiographic form, the BAS-DAI is quickly lowered and kept under the threshold of 4. So 1 out of 3 patients will have inactive disease in non-radiographic axial SpA, and 1 out of 4 patients have inactive disease in AS. So this is very significant for our patients. So what about pain? We know sometimes that pain has like a different progression than the disease activity. So this is a study, the skip pain, about spinal pain as early at week 8. And also, the design is very interesting. So they took the treatment versus placebo. And at week 8, if they responded or not, according to the threshold of pain, they kept them on 150 or increased to 300. Okay? And so the pain improved as early as 8 weeks, and it was maintained. Also, fatigue improved, ASAS health index also were improved. So it was quick, and it was maintained. And people who increased also the dose responded better. So we have this option to increasing to 300. CRP also improved, not only pain, and bone marrow edema MRI also improved. And most importantly for us, we want to see the radiographic data, which is very difficult to demonstrate in axial SpA. It's not like in RA. 79% of AS did not progress, 97% of non-radiographic SpA did not progress. So the key clinical trials really shows a very impressive efficacy on our patients. What about the strategy trial, head-to-head and real-world data? So we have one head-to-head study compared to adalimumab, the SURPASS study. So they compared adalimumab to secukinumab head-to-head, and they showed that both had the same risk of low radiographic progression. And they included patients really at high risk, like high CRP and at least one syndesmophyte. They studied also in the SURPASS study subgroups. So they studied people with high CRP and syndesmophytes, and they found that across all the groups, it was similar between the two drugs. But also they identified high-risk group. If you have high CRP and syndesmophyte, you have a higher risk of progression. And if you want to compare syndesmophyte and CRP, the worst thing you can have is syndesmophyte. both of them, then syndesmophyte, then CRP. So if you have one syndesmophyte, you really have to be aggressive. And we also have one real-world study, and we know from our patients that the patients that we see in the clinic sometimes are not the same as the patient that you have in the trials. And this is the Serena study, 524 patients with PSA, 473 with AS. They followed them for 3 years, and the retention rate, which is a combination of efficacy and side effect and safety, was 74% and 77% for PSA and for axial SpA. So a very high retention rate, which is really translating a good effect on efficacy and on safety. So this brings us to the last part, safety. This is what matters to us the most in the clinic. So luckily, Cosentyx has been widely used in the world. More than 400,000 patients treated, 14 plus years of experience, more than 100 clinical trials. We tend to think that our patients with AxSpA are young people, so they don't have comorbidities. But actually, if you look at them, they have comorbidities. 30% have hypertension, 23% have dyslipidemia, 10% have depression, 10% have diabetes, uveitis, malignancy, CAD, etc. They have a higher risk of VTE as well compared to the general population. So these are patients who are not really easy patients. So we need to take care of the safety profile. And luckily, with Cosentyx, there are no trend toward increased risk of malignancy, MACE, even IBD, and I will show you a slide in a while. No new safety signals, including pediatric patients young as 6 years. No warning about viral reactivation, HBV, HCV, herpes zoster. No clinical drug interaction. No worrying about VTE. And no need really to monitor for neutropenia, lymphopenia, anemia, lipids, liver enzyme elevation. We do it, I do it in the clinic, but the data is safe. So what are the side effects that we can see? So mostly serious infection, 1.2 per 100 patient year. And the most significant one compared to the other drugs that we know is candidosis. But the risk of MACE, even here in Crohn, ulcerative, IBD is less than 1 per 100 patient years. This is in AS, and you have the same in non-radiographic. And this safety profile is maintained over the years, and this is data up to 6 years, and you can see very clearly here that there are no increasing in the side effect, and you can see also that the number of patients is very important. Here at 6 years, you have over 2,000 patients. And finally, what happens if you have a pause in treatment? So this is data that we are taking from PSO, and in our countries, we always have pauses because the drug is not available, the patient does not have enough money, the ministry is not providing, etc. So the good news is if you stop and the patient takes it again, it will be again have the same efficacy. So what does it say? It says that the drug has no immunogenicity. Okay, so this is very reassuring. And lastly, what the patient lacks the most is the simplicity of once monthly maintenance dosing. So after the loading dose, weekly dose, you have the maintenance dosing once every 4 weeks. And the pen is very easy to use. The patient will not see the needle. So in summary, my 5 points from the 5 countries. Secukinumab, Cosentyx is well established now in our daily practice, even as a first-line biological DMARD. Interleukin-17 is a key inflammatory mediator in axial SpA, and especially in bone forming. Secukinumab has a significant positive impact on daily living in patients with axial SpA, and I have showed you data on pain, on CRP, on MRI, on radiographic progression. So the key randomized clinical trials, head-to-head trials, real-world evidence have really shown very nice data on pain, disease activity, and radiographic progression. And all of this is combined with a very good safety profile, very reassuring, and very low immunogenicity. And with this, I would like to thank you for your attention. Thank you.
Hello. هاي سامي.
بستولورزز يعني بنشوفها نادرة يمكن هالحالة. شو بإيش تعالج؟
So when he was switched to secukinumab, he was so first the joints got better and then the skin got better.
خلاص كذا فيش أسئلة ماشي.
But the skin took much longer.
دكتور لاي تفضل.
So regarding the loading dose of secukinumab, I see that you have the same problem as in our country, Palestine, that the medication interruption is still there and the medication is not available most of the time. Do you still give loading dose for patients with radiological axial spa or not?
لا طبعا.
So, for example, now our ministry is planning of skipping the loading dose because, like, with one loading dose, they can treat more patients. And I have shown you the data that it is equivalent, so almost the same ASAS, like around ASAS 20, around 60% of ASAS 20 with and without loading dose. Now, I think that with patients who are more difficult, like very high inflammatory markers or who have already failed TNF because they are more difficult, I think we should push for a loading dose and even 300 milligrams. But for a regular patient with not a lot of bad prognostic markers, I think if we are in a low resource country, we could skip the loading dose.
حتى بنجيب أي واحد بتحب تجيب من الشباب.
شكرا كثير للكل.